In Unit 3, I will provide an overview of cancer screening, diagnosis and staging of cancer, and the treatment of cancer. Firstly, cancer screening. We learnt in Unit 2 about the multi-stage nature of cancer and that the progeny of a cell that initiates the first phase in the formation of a cancer, such as the loss of the APC tumour suppressor gene in colorectal cancer, may take up to 3 decades to progress through the other phases and to begin to metastasize. This is extraordinary in that there is therefore a large window of time to intervene with early improved detection methods before the tumour can invade surrounding tissues and metastasize to other organs. As we know, tumours that have metastasized to other organs have a reduced survival rate compared to localized tumours. Screening of the general population or defined cohorts, such as people of a certain age group, is therefore used to detect the presence or abnormalities such as benign tumours and indeed early stages of cancer, often before symptoms begin. The origins of cancer screening can be traced back to 1923 when George Papanicolaou developed the PAP test as an early screening tool for the detection of cervical cancer. It was not widely used until the 1960s. However, since its adoption as a screening tool, cervical cancer death rate has reduced by about 70% in the USA. In Ireland, there are a few cancer screening services in place to detect cervical, colon and breast cancer. Next, we will look at the diagnosis and staging of cancer. The diagnosis of cancer, particularly solid tumours, usually utilises one or more methods including imaging techniques such as computed tomography or CT, magnetic resonance imaging MRI, ultrasound and positive emission tomography or PET. If cancer is suspected, a biopsy is usually ordered to extract a small piece of the tumour using a needle, endoscope or surgery. Surgery uses either an excisional biopsy, that is looking at the entire tumour, or an incisional biopsy, part of the tumour, to aid in the diagnosis. A common system to classify the extent of the tumour is the use of the TNM staging system. T refers to the size or extent of the main tumour, going from Tx up to T4, whereas N refers to the number of nearby lymph nodes that have cancer, going from Nx up to N3. M refers to whether the cancer has metastasized. For many cancers, the TNM combinations are grouped into 5 less detailed stages, which are designated as Stage 0, Stage 1, Stage 2, and Stage 4. Stage 0 is carcinoma in situ for most cancers. This means that the cancer is at a very early stage, is only in the area where it first developed and has not spread. Stages 1, 2 and 3 indicate that cancer is present. The higher the number, the larger the cancer tumour and the more it has spread into nearby tissues. So Stage 3 is a more advanced cancer than Stage 2 and usually has a worse prognosis. Stage 4 means that the cancer has spread to distant parts of the body. Each cancer has its own TNM staging system, and we will highlight some of these in the disease-specific lectures within this module. Once a biopsy has been extracted or the tumour has been fully removed by surgery, the specimen will be analysed for shape, size and cellular features. Histopathology is a speciality in medicine that focuses on the analysis of the cells and tissues within the tumour. This often involves treating the specimen with a chemical called formalin to preserve the sample and to embed it in a paraffin wax to protect it. This is known as formalin-fixed paraffin embedded or FFPE. Thin slices of the specimen can then be cut and stained with, for example, cell stains such as hematoxylin and eosin to inform the pathologist of the tumour grade, for example, high or low grade. In addition, the sample may be stained with molecular markers such as DNA probes, RNA probes or antibodies to provide information on the disease biology. You are now directed to a web link that outlines how solid tumours are fixed and processed for histopathology. In this last section, we will look at the treatment of cancer. Traditional methods for treating cancer include surgery, to remove the tumour if it is accessible to the surgeon and that removing it would not harm the patient, chemotherapy, which is a broad spectrum of drugs with variable efficacies for different tumour types that usually affect both tumour cells and vulnerable healthy cells, and lastly radiation therapy, which uses laser beams to emit radiation that aims to promote tumour shrinkage through tumour cell apoptosis, also known programmed cell death, necrosis, that is non-programmed cell death, and cellular senescence. This is defined as where cells cease to divide. Historical treatments for cancer can be traced back to the ancient Egyptians, who attempted to treat tumours and cancers with cautery, that is burning, knives, which is a form of surgery, and salts, and introduced arsenic paste that remained in use as Egyptian ointment until the 19th century. Remedies for cancer were compiled by Pliny the Roman in his book Materia Medica. He recommended compound herbal and other remedies for internal use in advanced cancer before or after attempted surgery. Furthermore, his most highly praised prescription was a boiled mixture of ash of sea crabs, egg white, honey, and powdered feces of falcons. So surgery remains in use to this day as a treatment for cancer. In 1895, Wilhelm Röntgen discovered X-rays, and just 1 year later radiotherapy was used to treat gastric and basal cell carcinomas. Radiation therapy is a physical means to destroy cancer cells through apoptosis, necrosis, and senescence. It is called ionizing radiation because it forms ions and deposits energy in the tissues it passes through. It results in focused delivery to tumour cells while avoiding normal cells, and it causes direct DNA damage or the production of free radicals which can harm the tumour. At the end of the 19th century, Paul Ehrlich, a German biochemist, introduced the concept that chemicals might be useful in the treatment of disease. Specifically, he was interested in syphilis. Ehrlich coined the term chemotherapy. Chemotherapy, however, was only tested as a treatment for cancer in 1943, and we will now discuss this in more detail over the next few slides. In 1919, Edward Crumbar, a US Army pathologist, was the first to notice that soldiers who survived mustard gas poisoning during World War I developed profound leukopenia, that is, a decrease in white blood cells, and the loss of lymph nodes. At Yale University, Alfred Zach Gilman and Louis Goodman tested the effects of this nitrogen mustard in animals bearing transplanted lymphomas, and here they observed marked regressions in the tumours in the animals. In 1943, Gilman and Goodman convinced their colleague, Gustav Lindskog, a thoracic surgeon, to administer nitrogen mustard to a patient with non-Hodgkin's lymphoma and severe airway obstruction. Intriguingly, there was a marked but temporary regression observed in this patient, and thus the use of chemotherapy was brought to the fore. To date, a huge variety of chemotherapeutic agents have been tested and approved, either alone or in combination as a treatment for cancer. Chemotherapeutic agents can be broadly classified as those that directly affect DNA, or those that affect enzymes and proteins that regulate DNA replication, or lastly, agents that disrupt microtubule function. In terms of the agents that directly target DNA, alkylating agents such as carmustine are capable of forming molecular bonds with nucleic acids or proteins, resulting in cross-linking or strand-breaking reactions. This results in inhibition or inaccurate replication of DNA, leading to cellular stress and apoptosis. DNA binding agents such as cisplatin covalently bind to DNA and form intrastrand and interstrand DNA crosslinks. This causes DNA breakage during replication, leading to cell death. Anti-tumour antibiotics such as doxorubicin intercalate between the DNA base pairs and inhibit DNA synthesis and transcription. In relation to chemotherapeutic agents that target enzymes that regulate DNA replication, DNA topoisomerases such as etoposide stabilize the topoisomerase II DNA complex and prevent DNA unwinding prior to replication. Antimetabolites such as cytarabine is a naturally occurring deoxycytidine analogue, and it inhibits DNA polymerase, which is required for the replication process. Finally, microtubule disruptors and microtubule polymerizers are commonly used as chemotherapeutic agents. Microtubules play key roles in maintaining cell shape and the movement of organelles through the cell, but perhaps they are best known for segregating the chromosomes into daughter cells during cell division. Microtubules are hollow, cylindrical structures that are comprised of alpha and beta tubulin. Microtubules are very dynamic structures and constantly grow and shrink. Microtubule disruptors such as vinblastine promote microtubule disassembly during cell division. In contrast, microtubule stabilizers bind free tubulin and promote the formation or stabilization of microtubules, resulting in mitotic arrest, that is, they block cell division. As you're aware, chemotherapy affects both healthy cells as well as tumour cells, and therefore there are always significant side effects when administering chemotherapy to patients. Combinations of chemotherapeutic compounds are now commonly used for the treatment of certain tumours. In addition, chemotherapy is often combined with other treatment modalities, such as surgery and/or radiation therapy. As I mentioned, chemotherapy often affects both cancerous and vulnerable healthy cells. This results in side effects such as hair loss and nausea. And chemotherapy is an example of the one-size-fits-all approach to the treatment of cancer. It has long been known since ancient times that tumours are resistant to treatments such as chemotherapy and often re-emerge following treatment. I will now discuss some of the reasons why tumours become resistant to chemotherapy or can re-emerge. For example, at the time of diagnosis, many tumours are heterogeneous and contain numerous subpopulations of cells that have different biological characteristics, including metastatic potential. Thus, some cells may be sensitive to chemotherapy while other cells may not. In addition, there are significant challenges in delivering the chemotherapy to all cells in the tumour, as anti-cancer drugs, like all drugs, are subject to absorption, distribution, metabolism, excretion, as well as transport across the tumour vascular and through the extracellular matrix. Furthermore, after removal of the tumour by surgery, micrometastases may remain that are not visible in the patient by imaging and may form new tumours at a later date. Another couple of reasons why tumours are resistant to treatment and often re-emerge following this treatment is that metastatic tumours from the same person are often different in terms of their molecular profile and characteristics, rendering treatment challenging. Another important point is the presence of cancer stem cells, which are defined as a cell within a tumour that possesses the capacity to self-renew and to cause the heterogeneous lineages of cancer cells that comprise the tumour. Cancer stem cells are often resistant to therapy and outgrow drug-sensitive tumour cells over time. Some other reasons why tumours are resistant to treatment and often re-emerge following treatment is due to bypass signalling. This is ancillary mutations in the targeted protein, or indeed compensatory modifications to other components of the same pathway or parallel pathways. Thereby, in the presence of the drug, the cell can use alternative pathways for growth and survival. Another reason for drug failure is due to the upregulation of drug efflux transporters. These transporters can transport the chemotherapeutic drug out of the cell. And lastly, some cancer cells have an intrinsic resistance to apoptosis. In these cells, there are activation of signaling pathways that promote resistance to cell death from the outset. In this final subsection of Unit 3, I will discuss the current landscape for treating cancer, particularly targeted therapies. In more recent times, the characterization of molecular aberrations present within cancer cells has led to the development and clinical approval of targeted therapies. These are defined as therapies aimed at a specific target or signaling pathway in cells. This includes small molecule drugs and monoclonal antibodies. Small molecule drugs may inhibit cell signaling by interfering with the actions of protein kinases and therefore blocking phosphorylation of its substrates. Here the inhibitor usually needs to be of low molecular weight to enter into the cells. Small molecule drugs often target protein kinases. Because they are chemical in nature, they can be usually taken by oral routes. In contrast, protein-based monoclonal antibodies cannot be taken orally, as they would be broken down by the acidic nature of the gastrointestinal tract. Furthermore, monoclonal antibodies are large protein structures and they are usually not cell permeable. A targeted approach using small molecule drugs or monoclonal antibodies can spare healthy cells if the treatment specifically targets an aberrant pathway only present in the tumour cells, as opposed to chemotherapy, which is administered systemically and harms both tumour cells and normal cells. Two targeted therapies that have revolutionised the treatment of cancer include the small molecule drug imatinib, which is used for the treatment of chronic myeloid leukemia, and monoclonal antibodies such as trastuzumab, which is also known as Herceptin, that targets overexpression and amplification of the HER2 gene. Trastuzumab is used as a treatment for breast cancer and gastric cancer. So while targeted therapy has now joined with surgery and chemotherapy and radiation therapy as mainstays of cancer treatment, another relatively new method for treating cancer is immunotherapy, which mobilises the patient's own immune system against the cancer. Immunotherapy will be the subject of a lecture later in this semester. While there has been a revolution in the development of new treatments for cancer, there also needs to be development of diagnostic assays so that the right patient can be matched with the right therapy at the right time. Clinically approved molecular diagnostic assays for cancer include real-time polymerase chain reaction, immunohistochemistry, DNA sequencing including Sanger and next-generation sequencing, RNA sequencing, in situ hybridization and microarrays. We will discuss many of these assays in the next lecture.